So this is my patient. She's very sad. I'm on a lot of meds. You may have met her. She's 72 years old. She's an ex-smoker. And she's presented to the emergency department with crushing central chest pain that lasted about 90 minutes. It's gone away without any treatment, and of course, as is often in emerge, there's not a lot to help us direct her care. Her troponins are negative, and her potassium is slightly elevated, non-specific ST changes in her EKG. You can see on the right-hand side of the slide there her past medical history and surgical history at the bottom. It's now 10 p.m., and of course, she is admitted. So what we'd like to do is sort of shout out or raise your hand or have a conversation about some of the issues that are going to happen with this patient. So just take a mental picture of her admission list, and what a med rec is a medication reconciliation. And so any patient that shows up to the emergency department will have one of these on their chart. And it has on it a list of all the medications they've had, and you can set a parameter like how many months or how many meds or whatever you like, but typically about 6 months worth of medications is printed out, and highlighted on that in chronological order from now going backwards is the ones that they're on currently or considered to be a current one. It's not always correct. Sometimes you'll see like 90 days of something prescribed on May 30th, and you're doing the math and you're figuring that shouldn't be current. It should be gone, but it's still marked as being current. So we use this with the patient and the nursing staff, and sometimes if they've come from a nursing home, their medical record that they have checked off when they've given the patient meds to figure out what exactly they're on in the community, which may or may not be true. So one thing that we know is that if the patient gets samples, then it's not going to show up on a med rec. So there may be things that they're also taking in addition to these that, a new antidepressant, for example, or an anti-inflammatory with stomach protection, or any of these newer agents, some of the long-acting narcotic things that won't show up on here because it wasn't actually a prescription. So this is what our patient is on. In the hospital, it was fairly uneventful. She had serial troponins and EKGs, then a stress test the next morning, which was equivocal, of course, because everything's always equivocal. And on day 3, she felt well, and she was up and around, and she didn't have any more pain. So she was discharged home with an appointment for a MIBI and to see Dr. Sui in about a week. And she was told to see her doctor in the next week or so. See where this is going? So the hospital food is awesome, and so she's gained a little weight and had her hair done. But here she is the second day after she's been discharged. And the doctor is very concerned and is listening to her very carefully when she says, "I'm not really sure what happened in the hospital, and why are all my pills different?" And so here are her medications. And so you see the stars there are the ones that have been changed. So it was enalapril before, and now it's ramipril. It was simvastatin before, and now it's atorvastatin. The Nexium's been changed to Pantalac, and the dosage of her Zopiclone's been changed. Discussion? So does anyone have an idea what happened there?
Well, we know that the medicine get changed because hospital pharmacy only provides certain medicines. But it does cause us a problem because when the patient comes back, they're now on different medications.
That's right.
And we don't know the current list, a lot of it.
Where do we get it from? It's printed off in the emerge. Pharmanet, yeah. So here's some of the issues. When will the discharge summary be ready? Why are all the meds different from the ones I prescribed? And is there something I'm supposed to be doing with this patient on day 2 post-discharge? So I'd like to ask our hospital pharmacist to come up and just have a little talk about issues around. Explain.
I brought goodies, but I got her.
Explain. And maybe also after that, a few words from our community pharmacists about some of the issues they see.
Thank you, Dr. Kelly. I brought some goodies as samples, and it's very much related to question number 2, why the heck are those medications so different? So I have brought samples. What we call ATI is a short form for automatic therapeutic interchange. I don't know what everybody wants. There's multiple pages, but I can, I'm going to just maybe, yeah, I'll just set them in here. I put them, it's from A to Z. What we have is, there's a group called Medication Utilization Evaluation Group, and for Fraser Health and as well as the other side of Boundary Road. So they work with the government as well as doctors group, and they put recommendation to the PNTs, which meets 3 times a year, I believe. Correct me if I'm wrong, but.
Jared, can you stand up so we can hear you?
No, that's not true. So I'm just going to put them set to the side. Yeah. Can you hear me? Yeah. Perfect. So what happened is the MUE group, which is PharmDs as well as the doctors, they look at classes of medications and they evaluate them. And if it's a class effect, they will group them together. For example, this particular one, enalapril, changed to ramipril. And that is a little bit old data now, Dr. Kelly. Now the ACE inhibitor, which is a class of all the prils, the class that we use now is a trandolapril. So now if the patient come in with enalapril, and we would have one of these forms, which will just, I'm going to put it down and you guys can take them home, and there's got information on the back and say if it's on one of the prils, whatever milligram, what will it translate to the most current one we have. And these get changed maybe every year or 2 years. So this one is dated 2013, so it hadn't changed for about 2 years now. So what happened is there's a group from PharmaCare look at the cost of medication. So on this particular, under ACE inhibitor, under A, it got 1, 2, 3, 4, 5, 6. 6 of them on this side, and they all will do the similar things, cardiac protections, dropping the blood pressure, and everything else that you guys are all well aware of. So what they do is they tender out for the hospitals, which is all 13 hospitals in Fraser Health, or all 26 hospitals in the Lower Mainland, and they will look at all the drugs and they say, okay, if I use this drug from all the blind tenders, I will say, let's say, $3 million for all the patients in the Lower Mainland, and they will make this change. So this was changed in 2013, but prior to 2013, everything that from any, like, so if you have a patient on quinapril coming in the hospital, got admitted, they will get onto ramipril. But currently, we'll be changing to trandolapril. So there is probably about 5 pages of them from A to Z, and a lot of them have this automatic change. And this passed through the PNT, meaning that I do not have to phone Dr. Kelly, or I do not have to phone Dr. Richards or Dr. Bashu. Then I go, any patient on this drug is been passed through PNT, so we call it automatic therapeutic interchange. And then we will sign our name, the pharmacist's name, say, this is now changed. So when a patient gets discharged, when, is it the unit clerk that prints it out?
We print it that.
You do?
We can ourselves.
Okay, so whoever prints it out will just spit out a list of medication that we have substituted now. So then when they go to drugstore, they will totally look different. And I totally see the difference between the patients and the family, because they will come out and say, they look different, they're different, but in our point of view, they do the same thing to the patient because it's equivalent. I used to, that when I see these orders, and I would say on a little bracket, it say, this is substituted for blah, blah, blah. But we are so busy now that we cannot, on every single patient, type this equivalency, so then it doesn't print out on a discharge summary. So this may explain that. Is it satisfactory? Okay. Any question?
The cost difference, is that just the hospital because of the volume they're buying? Or
It is the hospital. No, there is an organization called Health
Pro, which does all the negotiations for the hospital. It's not just my hospital, it's all the hospitals. So once that evaluated and go through, then it go to a group purchasing, which purchase for all the hospitals. It's basically a cost difference.
So if that's the cheapest one to the hospital, it's not necessarily the cheapest one that's in the community.
No, no. The community have a different fee structure. They do not have the buying power. Perhaps if all the Shoppers Drug Mart get together, they would have that same power. But I believe they're individually owned, so they do not have the negotiation power. I see a hand at the back before. Yes.
Since you know what the patient was on when they came in,
Yes.
why not put them back on that when you're discharging?
I would be.
If they were on run through and they were unavailable in the hospital, now they're being discharged, put them back on what they were, because oftentimes they have bubble packs at home that have already been made with run through in it.
Absolutely. We actually do not break up the bubble packs when the patient comes in. We always use our own supply. But the workflow is such that sometimes I have no idea when your patient get discharged. And just like when the patient's death is not apparent to some of the offices.
The question is for the hospital is to say, you know when they came in what they were on. They got auto substituted in the hospital. Just put them back on what they were before. It will save a whole lot of headache.
So
So if you are changing it,
I think
you
as-
need to
Sorry, I think the question is not to do that. The question is, obviously, it needs to be done to put the patient back on what they were. What I'm just saying is that this is the challenges that are happening in the hospital. You know, we have patients coming and going and things like that. And that's the problem, you know, that we face as well. You know, trying to discharge the patient and put the patient back on what they used to be. It's not that we want to change the medication to what we have in the hospital, but, you know, it is a kind of a system problem.
where is the system problem when they are now leaving this hospital? They are not going to be limited by what's available in the hospital. You know what they were on before. Put them back on those medications. Then it saves us a lot of money. Number two.
You don't always know what they're
Number two is that sometimes you do use medications or start medications that require special authorization. And patients come back to the office saying, this cost me so many dollars because no special authorization was obtained. I believe if you are starting the medication, you should be getting the special authorization for that patient. Then they don't undertake unnecessary expense. These are elderly, most of them on old age pensions.
I think I realize the challenge of doing the discharge and changing the medication back. I think for me personally, but I guess we would have to come to some agreement, is more to know the changes. If for some reason we decided that the patient should be at a different staffing because whatever, to make that specific change just clear. I'm more interested in in the clarification why a specific. So if they come back with a couple of things, it looks like it was an automatic substitution. I can sort of look at that. But if I know that one specific drug was chosen for a specific reason, either a call or something that happened, I would just like to know why that's one specific thing was changed. Otherwise, I would assume that it needs to be just reverted back into the process. If because there's going to be communication gaps, and it's not going to happen, because of time or whatever. So unless if there's a discharge that if there's a specific reason for something it has drug change, whatever, that's something I think should be left.
What Shraz Rawani said, we would save a lot of money because some of these patients, when they go into the hospital, they already have 2 months or 3 months supply of the one statin, and they come back on a different one, although they may notify you, but this still incur cost. So if we can reverse it back to what they were on before, then the patient is not confused. They know which pills they were taking before and they can take them now. Because we have sort of, a lot of the time we have taught them you're taking this for your cholesterol, you're taking this for this, and you're taking this for this. But now they come back and the color change and the name change, so they don't know what they are on for what. So for that reason, I think it's important to put them back on what they were on before they left, before they were admitted.
Very well said. I'm hoping that this will be information exchange, so at least if you take some of this home, at least some of the bigger category, you can understand. A lot of them because of that class effect. But I also echo the Ursula's mention, because sometimes even we substituted it, the dosage is still adjusted either upwards or downwards, and then it's not, as a matter of fact, just changing it back to what it was, because that would have been wrong, because they adjusted the new medication based on the effect. So it might be a bit, it's a bit more complicated than we say just switch it back to what it was, then you would negate what was changed.
Yeah, I want to just answer something to that is, a lot of times what happens is the specialist gets involved in the patient coming into the hospital, and although they say you like to use a certain ACE, they tend to use a certain one as well. So the thing is, Winston will like to use this, Bart uses this, and Sindar are the same. So the thing is about it is, a lot of times they adjust the medication because of their preference or what they feel is the most appropriate as well. And it's not always that it just changes because of class effects and shit like that as well. They have preferences of what they use. They specifically use certain statins and wouldn't use simvastatin at all. So if somebody comes in with simvastatin, with an MI, they would often never put the patient back on simvastatin.
But you don't know that the patient didn't have muscle pain with Lipitor or whatever in the community, which is why I switched them to simvastatin.
No, I agree with what you're saying, but what I'm saying is, I'm just saying why certain things happen.
Yeah.
I'm not saying that you don't know any other information about the patient, but there's sometimes reasons why the specialist changes is that it's not just a class effect for the
But that needs to be communicated to us.
Yeah, no, I agree.
So, and that patient needs to continue along that same line, why would they just continue? Yeah.
Yasina, did you have something?
Well, I think I was just adding to the same conversation where when we get the prescription from the hospital, and we're the last person the patient sees before they actually get the drugs. So we have to scrutinize that prescription, and we really appreciate when it says auto-set or something, because we always change them back to what they were before. And hopefully the dosage, when we check to make sure, but we never know whether the dosage was changed up or down, and it would be really helpful if it said dosage changed, auto stop, so we can give the patient what they had before. Because we used to have lots of problems with patients getting all upset and angry, and doctors changing them back within 2 weeks, and all that extra work. So if the discharge prescription would say auto stop on all the ones that were stopped, we can put them back, and a reason again for why some things were discontinued. Because the patient freaks out again when they come and say, well, I've always been on potassium, and why is it being discontinued? And we just have to give it, because it's a legal document, we can't just put in stuff. And 2 weeks later, they come back from the doctor with potassium audit. So, I don't know, if there was reasons we could explain to the patient why potassium stopped, or auto stops and increased in lower dosage, then we could just make it easy for the patient and physicians to have what they were on before.
A lot of times that information is in the discharge summary, which isn't yet printed.
So a lot of great discussion, and that's why we're here, right, is to try to talk to some of the challenges that both sides face. And we understand that there's no simple solution, but Shiraz, I hear your concern, and I think there is something that we can take back to the group of hospitalists that do the majority of discharges for patients in the hospital and work to improve them, because I think we definitely need to improve that process. So I do want to speak a little bit. I know we are, I'm conscious of time here as well. So I just want to speak a bit to the first and third point that Laura brought out here. when will the discharge summary be ready? We in Fraser have, as you probably are aware, have a consolidated transcription service, meaning we dial one number. It doesn't matter if you had an OR or an admission, or emerge doctor does an admission, a history and physical, or a hospitalist does a discharge summary. We all dictate to the same transcription service, and we are competing against other health authorities for the same transcriptionists, and we faced a bit of challenge with that, right? We understand that the volume of discharges, dictation, and as a whole has gone up, and that's increased the turnaround time. I think there was a period of time where it was taking over 7 days for transcriptions to get from the time of dictation to into your offices, fax to your offices, and into your EMRs, and that's just unacceptable. And so the standard that we are using is that within 48 hours, you should be getting a dictated discharge summary into your office. I have been told by dictation services or transcription services that that target is being met currently, and we have had to crack down on some physicians that are prioritizing their dictations over others, as there are ways that people can do that. But I think I need to hear from the community GPs, and it may not be in tonight's venue, but by email or phone. If you are facing challenges with receiving our discharge summaries, I need to hear that, because I'm only as good as the data you give me, and what I'm hearing from the most part is that within 2 to 3 days you have that in front of you, and that's why we try to book an appointment for follow-up maybe 5 or 7 days down the line. We never say, unless there's an INR or something else that needs to be urgently followed up on. I very rarely will tell a patient to see a family doctor within 2 or 3 days. So I welcome your feedback about that, and I'm hoping to see the discharge summary and dictations into your office sooner. And then Laura's point about, is there something I'm supposed to be doing with this patient day 2 post-discharge? I'm not sure what to say to that, because I guess a lot of information, valuable information, is usually contained in the discharge summary, including next steps and steps for follow-up. And without that information, I guess we're kind of handcuffing you. Vern?
The discharging doctor may have in his mind why he wants the patient seen 3 days later. There may be some important stuff that he wants followed up.
Sure.
And that needs to be communicated. That is only something by maybe a phone.
Yeah, I agree, and
Patient has
that's
decided
right.
that they just want to see.
Very often what Willem and I try to do, and I think we're trying to share this with the rest of the hospitalists, is if there is an urgent need for a patient to have follow-up, we try to get on the phone with the doctor as opposed to leaving it to the patient. And I think we're trying to make it so that if there is a need to follow up with the patient within 3 or 4 days or sooner than a week out, we would be on the phone with you. If you don't hear from us and a patient shows up in your office, chances are they probably pre-booked that appointment with you, and there's nothing that we would have done differently. But I can't speak on, and again, I'm cognizant of the fact that there's 20 hospitalists that work in our hospital, and internists and other service providers and surgeons that discharge as well. So we're not all the same, and we all do things a little bit differently, but I think we need to try to ensure that from a patient safety point of view, if there is urgent follow-up that's required, that we communicate more effectively. Because what I'm hearing today is that communication is the ultimate solution, a step towards a great solution, and we need to continue to communicate. So, Laura, do you want to continue with the presentation?
I just wanted to say that from my point of view, I have nothing but praise for the discharge notes. They're coming quickly, they're very thorough, and they give good information for me to continue on. So thank you for that.
Great.
So our next case is Mr. Redman. And these are Mr. Redman's legs. Mr. Redman is in his late 40s. He has a history of type 2 diabetes, blood pressure, venous stasis, and recurring infections in his legs and atrial fibrillation. Of course, it's the very last patient on Friday afternoon, and he comes in with red, painful lower legs for 4 days. He had a little fever last night, but he's not septic, so you don't need to rush him into emergency. But you know that he needs IV antibiotics. And you're very, very conscientious, doctor. And so you get out your IV therapy orders, which we have some over here on the side. And so it's ordered for him to have IV Ansef with oral Cephalex in 6 and 12 hours after the IV Ansef. They're all faxed in. The patient shows up to the emergency and waits for 4 hours, which is the exact opposite of what you had intended. Blah. That's me. It actually looks more like April. So I'd like to introduce Sherry Taylor, who's one of our directors and is going to speak to the IV therapy program. I have something else on that slide.
Thank you, Laura. Hi, I'm Sherry Taylor. I'm one of the directors at Ridge Meadows Hospital. In particular, I have the community stream. So I have residential care, home health, home support, I have emergency, and I also have a couple of the outpatient clinics, in particular what we're going to speak to tonight around the, I call it OPAT, so antibiotic outpatient therapy. So, and I also have medical daycare and oncology. So I'm going to do a little bit of myth busting tonight. We can probably just go right to the next slide. And I'll have to say that Cassie had really meant to be here tonight. She's the manager of emergency, but she was unable to make it. So I'm your Cassie this evening. So one of the questions that always comes around from the GPs is, can anybody refer to, okay, I'm going to keep on calling it OPAT. Can anyone refer to OPAT? Can anyone write orders for a patient to go to have their IV therapy done at OPAT? Yes? Okay. But there seems to be a myth out there that that's not true. So I actually was a director of medicine in Surrey, and I had the Jim Pattison Clinic. And we also had a myth out there in Surrey as well, so that no, you couldn't send patients over to Jim Pattison either to the OPAT clinic. So in fact, yes, anyone, any physician can send their patient over to the clinic, including medical daycare, if they have the orders in place. So we've busted that myth, so that's good. But there are some things that we really want to make sure are in place. So Cassie thought it would be really important to walk through what would that journey look like for our patients that would come to your office and what would need to happen for them.
I'm just going to hand out some of these. These are our guidelines.
Oh, perfect.
And orders. They're new. They're
Okay.
actually being rolled out on Monday.
All right.
So I'm just going to hand
Perfect
out
timing.
everybody.
Okay.
I think Ursula should posted it in, so I'm just going to do it.
And I really wanted to say that we do, in our OPAT and our medical daycare, we actually are underutilized. We actually want more patients. So this is about improving access and increasing capacity. So we really want to divert our patients from coming to emergency and accessing our outpatient clinic. All right? So what would that journey look like for a patient coming to your office? They're going to come, you guys are going to assess them. You would complete the PPO, and you would fax it over to the clinic. What's really, really, really important is they need to make sure they have the contact information of your patient. Because when it gets to the clinic, they are going to need to contact your patient to make sure they can book an appointment. And so there's been some glitches around the contact information. So the patient then reports down to registration when they arrive for their appointment, and then they're directed to where the IV antibiotics are going to be taking place. And for those of you, do you guys know how many places at Ridge Meadows Hospital we're doing IV antibiotics right now? If someone gets it right, they get dessert. Who knows how many places in Ridge Meadows Hospital currently right now, including the entire campus, IV antibiotics is happening? 3? No, wrong.
4.
4 is the correct answer.
I studied.
So you get dessert.
And insider information.
Okay, so tell me the 4 places then. So Laura, what are the 4 places? Emergency.
Always. Upstairs on 3 West, there's a little satellite.
Yep.
Downstairs in medical daycare.
Yep.
In the mornings usually, and home health.
Yep. So that's right. So those are the 4 places. Did everyone catch that? Yes. So what we are, just a little bit of a side note, we are working on a project that Cassie is actually leading right now around improving our services around how we're delivering our outpatient antibiotics therapy so that we can create a one-stop shop so that we don't have patients going all over the place and have services being delivered in one area. So we are working on that right now. There'll be more to come around that. And having our reassessments being done in the clinic and not in emergency. So we're going to be looking for some physician support around that, around the clinic piece. So more to come around that. So what happens for the patient? They come down, they come and get their IV antibiotic therapy. They might come in the morning and go to the clinic, or in the afternoon, or in the evening, they might go to 3 West. So it's a bit of a crapshoot where they're going. And then the patient is going to come back to your office for the reassessment based on the date that you've asked for them to come back. So that would be our ideal journey. And then in this journey, they're not going to emergency either. So Laura, is this a normal journey that we're seeing now, or what would be, or from the consensus from our ERPs and the emergency and the GPs? Yep, Janet?
This is great that I disseminated this question, but where is the fax order to? I think they just use the fax to emerge, and this is where things happen, or...
Oh, it's being faxed, actually it's being faxed to the clinic. The IV therapy clinic. So we'll make sure that everyone gets the fax number for the IV therapy
It's
clinic.
not on that paper.
And it's not on the paper, okay.
Well, the paper is regionalized.
Yeah.
And can I ask Janet, because at some point I started the capacity pharmacy so that it could be prepared, things like that. Is that
Depending what drug it is, Cefaclin and Cefaclin is better stocked in the clinic and emerge. Certain things, let's say the patient needs vancomycin or vancomycin or something that is exotic, then we may need time because the patient showed up, it's not going to be there. Then it is up to the clinic to fax it to us, and we don't open as late as they do. So that might be a bit of a problem. Whether or not it fax to us, it's just a delay or not delay, but depending what time. If it's during the daytime, they fax to us, great, we know. But ultimately, the nurse needs to know more than we do, and if they have drugs, great. If not, then they should phone us and all they do is make up to get it. They might do it today, we didn't know. But most of the stuff, Cefaclin, clindamycin, Cefaclin is on there.
Sorry, Jen, I think in order to streamline this process, what we're trying to create is a central
Yeah.
repository, a central place to go.
Yeah.
So everything goes to...
Everything will go to one place.
That nurse then contacts pharmacy to ensure that the drug's going to be in place, and then contacts the patient to say, come to the registration, and we'll inform the patient where to come, at X or Y or Z. So we're trying to avoid duplication and errors that happen and inefficiencies at the end of the day. So one central stop is what we're looking for, and that's where the outbreak is.
It'll be a one-stop shop, one number, and one central fax number. Yeah.
I've never seen a restricted drug form in any of the clinics. So, you know, if you need to use like imipenem or, you know, those type of antibiotics.
So you're speaking of our antimicrobial stewardship?
Drug policy in Fragile, and we need to fill in those forms. So,
I just write it on an order,
Yeah.
No, they have those forms.
not in the clinic.
So not in the clinic.
I'm saying the outside.
Outpatient.
The outside clinics, we don't have any forms.
Okay, well, we'll take note of that then.
Well, we do from the clinics then get back those ESBL E. coli's where there's only
Okay.
one antibiotic that they're sensitive to. And if I'm at Crossroads or Cottonwood or wherever I happen to be that day, then I need to have that.
Pharmacy does not stop, like, we do not essentially supply those drugs just because it's not in the form, but we prefer to have that for that medical stewardship.
So for the community GPs that aren't aware, there's been a big push at Fraser to restrict certain antibiotics from being dispensed for inappropriate reasons.
Janet.
Like ertapenem and imipenem and meropenem, we try to save those for febrile neutropenics and people that actually, you know, have resistant bugs. In the hospital, it's a requirement that any physician that's ordering those medications in the hospital has to indicate why. So there's a standard form that goes with those antibiotics that we have to fill out. That's not the case in the community for patients that are seen in the offices. So what we will take back to the Antimicrobial Stewardship Committee is how we can improve the dispensing of those antibiotics from an outpatient point of view. We'll take that back. I'm sure we're not the only community that faces that. So.
And with extended hours that we're looking at trying to achieve, we'll have better opportunities to be more aligned with antimicrobial stewardship as well. Any?
Shred?
Oh, sorry.
It would be useful as well to get antibiotic therapy recommendations as well for our area.
So one of the recommendations that have been brought forward is some education, just to support and align with exactly around the antimicrobial stewardship and some of the antibiotics that are being prescribed right now. Yeah. So one of my questions I had, that Cassie had here too, was what opportunities do you see? Is there any other services that you would like to see in medical daycare in our OPAT clinics at Ridge Meadows Hospital to support the community and the work that you're doing?
Well, when we send for like IV, pack cells or something, sometimes the HB is 80, and say come in December for.
So you're impacted by wait lists?
Yeah.
Okay.
I'd like to see dressings done in the IV therapy.
So wound
Some
care.
of them get a daily house to do IV therapy, then they get a daily house for their dressings.
Then they have to go back to their GP to be reassessed.
And you're
So that
right.
patient's 3 days.
Yeah, we have patients going to home health for their wound care and then coming over to Ridge Meadows for their IV therapy. Yeah. So one-stop shop is what we're working towards. Yeah. No other questions?
Is this going to be separate from persons in need blood transfusions? We often get into the difficulty. I recognize on Tuesday that this patient's heading into trouble, but we can't get it in for another week because you don't want a weekend going away. You can't administer blood on the weekend where you should.
So this will be a 7-day-a-week. I mean, currently they are working 7 days a week, but we are going to be looking at Oh, it's not. Well, we will be working towards a 7-day-a-week, but we are looking at the inclusion, exclusion kind of criteria as well for the clinic. So we'll be getting more information around that, but we are working towards 7 days a week so that the weekends won't be impacted. Because we are a 24-hour operation.
Will that be in the clinic?
You know what? The inclusion, exclusion criteria needs to be developed. Yeah, and we will be aligned with other OPATs and medical daycares in the health authority.
One of the things I can see being an issue is right now the emergency doctor is going down and assessing the patients morning and evening, or the patients are coming up to emergency to be. And so on Monday, we had 3-hour wait in emerge, and I had 6 IV therapy patients that I had to reassess, which is an hour of work. But the patients sometimes have mobility issues. So they're already coming to the hospital for their hour's worth of Vanco, and now they've got to make another appointment to see their GP. It's difficult sometimes for those patients who, I think I would rather just get my thing and then book my appointment, but rather than wait another hour to see me. But some people can't, or they don't have a ride, or they're on a handy dart, or that sort of thing.
So from the patient experience, we want to make improvements there because our patients are waiting a long time. All right. Other questions? Thank you very much. So more to come. Stay tuned.
But that's all I have.